Welcome to Living Donor Liver Transplant, exploring the benefits and available resources. My name is Lorraine Stiehl, and I am the Chief Executive Officer of the American Liver Foundation. I'm also a caregiver to my husband, Chris, who is a transplant recipient. We are excited to be partnering with UPMC, the University of Pittsburgh Medical Center, to bring you this insightful webinar focused on the miracle of living donor liver transplant. Our experts will discuss the benefits of living donor liver transplant, what's new, and what the future looks like in the U.S. They will offer tips to help you navigate the often complex process and provide resources available to those looking for a living liver donor or those hoping to become a living donor themselves. At the end of their presentations, our experts will answer some of our most frequently asked questions, as well as some of the questions from the audience. So be sure to insert your questions in the Q&A box in the chat at the bottom of your screen. We'll get to as many as we can later in the program. Now let's begin. Please join me in welcoming our two expert speakers this afternoon. Swaytha Ganesh, MD, Medical Director of UPMC's Living Donor Program, and Lindsay Weslow, MSW, a Senior Social Worker with UPMC's Living Donor Program. Dr. Ganesh, would you mind starting us off with the benefits of this incredible life-saving option?
Thank you, Lorraine. Yes, absolutely. We'll be delighted to. So my name is Swaytha Ganesh, and as Lorraine introduced, I'm the Medical Director of the Living Donor Liver Transplant Program. I just wanted to have a conversation with you about what is living donor liver transplant and why do we think about this. Just as a background, as when someone develops end-stage liver disease, we can manage them as much as possible. But however, liver transplant is the established definitive treatment for end-stage liver disease. And a lot of you probably are already on the wait list, or you may have end-stage liver disease. And truthfully, though, we know that liver transplantation is the miracle of modern medicine. And we'll talk a little about the organ shortage problems and how we can overcome that through living donor liver transplant. And we have had excellent outcomes with the liver transplant with a 1-year survival of 87 to 93% and 5-year more than 75%. And just as a history of liver transplant, I like to usually narrate a story when I'm trying to learn something or when I talk about this or when I have a discussion with my patient. I usually start with the history. Where did we start and where are we now? And we know Thomas E. Starzl, the legendary surgeon, is the father of liver transplantation. His journey started at UPMC. He did his first liver transplant in 1981, and he did more than thousands and thousands of transplant, and he in 1 year he has done more than 600. And we didn't start doing living donor until 1999. And in 2017, we did more living donor than the deceased donor liver transplant because of the way our allocation system works. And in 2022, ours has been the largest living donor program for more than 5 years. And in 2025, we have been the biggest program in the country for more than 8 years. The only reason I say that is when we have more volumes, we have more experience as well. But also it emphasizes the importance of living donor and why we should think about living donor for every patient with end-stage liver disease. So despite the benefits, right, we'll talk about the benefits of living donor liver transplant, but despite the benefit, despite the benefits, why is the number of living donor liver transplant at US has not increased? When you look at the number of deceased donor liver transplant, the percentage of living donor liver transplant is less than 10%. In fact, it's actually less than 6 to 7%. So every institution is trying to identify what is the reason why we cannot increase the number of living donor liver transplants and what can we do as a physician, as a center, as a program, as in a country to increase the number of living donor liver transplantation. So why do we talk about this, right? Usually my patients ask me, why do you keep talking about living donor? Can you explain? It's because there is a disparity between the number of available organs and the size of the wait list. There are each year there are more and more waitlist candidates added to the wait list. Number of deceased donor can only grow so much, and the number of living donor liver transplantation in the US has been still only around 500 to 600, but the demands for the organ continues to increase in US, and all the patients who are on the wait list or who are being evaluated for transplant realize that when they get on the wait list, the first question they ask me is, Dr. Ganesh, what is the timeline that I could get a transplant? So that is an important question, right? So, and sometimes they also ask me, is there, this is a technology era, there is AI era. Can we increase, what are all the ways we can expand the donor pool? So, people talk about the xenotransplants, 3D printing, all that. And then for kidney, there is a bridge to transplant, which is dialysis, and we don't have that in liver. So right now, all of the studies which is going on, like the stem cell and the scaffold, it's not prime yet. So the living donation is the only and the most effective way to expand the donor pool. So I'll show you in a minute what the problem is on the wait list. There is a high wait list mortality. What I mean by wait list mortality is we list a patient for transplant. They get on the wait list. The urgency of the liver transplant is determined by a scoring system called MELD 3.0, which is Model for End-Stage Liver Disease. However, does the MELD reflect how sick the patients are? It does for 60% of patients, but for 40% of the patients, MELD score does not reflect how sick the patients are. A lot of liver patients know what the MELD score is. That is the score given to a patient when they get waitlisted, and the urgency of transplant depends on the MELD score. So to give you an example, when you are on the wait list at UPMC, unless your MELD is 32 or above and you're a O blood type, you're not going to get the liver until your MELD is 32 and you have no infection, you're ready to go, and your blood type is O, right? Usually for blood type AB, it's a little easier. A and B is similar, around 28. So you get the point that there is a lot of people waiting on the wait list, and there is a risk of dying on the wait list, and they also get sicker on the wait list. So that's why there is an increased wait list mortality, and we are not able to effectively transplant them at the right time unless they have a living donor. So let's see this. This is the current status of liver transplant in US. As you can see, this is the number of deceased donor liver transplant, right? Like starting from 1955 to now, slowly, 1990, sorry, I apologize, 1995 to now. So the number of deceased donors have gone up a little bit. The number of living donor liver transplant is staying as a line here. And then last year, we only did 600 living donor liver transplant in US, while we had 10,000 to 12,000 deceased donor liver transplant. So did it save the problem? No, because the number of patients on the wait list, these are the wait list additions. So, sometimes there are 14 to 16,000 people. So there is still a big gap of patients who do not get transplant at the right time. So the waitlist mortality in US, when I say waitlist, it's when patients are on the waitlist, they're waiting for the transplant. What happens to them while they wait on the transplant waitlist? So 17 to 25% of the patients do not have a chance of a life-saving transplant. They succumb to their disease before they have an opportunity to get a transplant. In liver transplant, the timing is of the essence. When you give the transplant at the right time, they do very well. And we know this. And only 40% of the patients get a deceased donor liver transplant after they get listed. And we also forget that there is a substantial high mortality among patients with a low MELD. It's not only that high MELD patients pass away on the wait list, but low MELD patients also have high mortality rate. So this is just an example to show this is the living donor liver transplant. This is the deceased donor. These are the patients who actually passed away on the wait list, and these are the people who are removed from the wait list because they're too sick or they are not eligible for transplant anymore. And these are the people still waiting for the liver transplant. As you can see, there is 40% of patients we miss not transplanting them at the right time. So there is a dramatic difference in the utilization of living donor liver transplantation around the world. So I'm from India, and living donor is the only way to transplant people because people there didn't believe in donation after death. So this is just an example. In a center called Azan Medical Center, they do more living donors than deceased donor. As you can see, they do 1,000, 2,000, 3,000 living donor. And the utility of the living donor is much lower in the USA, even though the people in United States are the most altruistic people. I'll show you the data for that. So so it is important to educate about living donation and have people come forward to be donors for our patients on the wait list. And so this is the utility of the transplant in USA, which is much lower as compared to some of the Eastern countries like Korea, Taiwan, Hong Kong, where their only way to transplant is the living donor liver transplantation. So I also wanted to show this, that we have seen survival benefit for patients starting MELD score of 11. And when you see, patients sometimes ask me, Doctor, my MELD is 12, so I'm fine, right? Yes, the patient with a MELD of 12 will be fine if they don't have any symptoms. Sometimes patients with a low MELD can have very significant symptoms of ascites being drained, encephalopathy, which is confusion, fluid in their chest, or they can have confusion, which is the accumulation of ammonia. So people, we used to think, oh, if your MELD is low, then you may not need a liver transplant for a while and you'll be fine. But that's not the case. Our studies show that we have seen survival benefit of living donor at MELD of as low as 11, and also approximately the same number of percentage of people who passed away with a low MELD is the same as the high MELD. So let's say there is high MELD, the absolute number for high MELD, let's say 2,766 people with a high MELD passed away. The same number passed away on the wait list too, 2,301. So that is eye opener, right? So patients with a low MELD have also high mortality on the wait list. So, allocation of a deceased donor organ, as I said before, is based on the urgency, utilizing the 3.0 MELD score, MELD 3.0. And the MELD 3.0 only takes labs into account, and it doesn't take the symptoms of the patient into account. So we used to start with the MELD, and then the allocation changed to MELD sodium, and now is MELD 3.0. You can even calculate your MELD 3.0. You can go into Google and say MELD 3.0 calculator. It brings up your age, your gender, and your albumin, INR, bilirubin, creatinine, whether or not you're on dialysis, and your sodium. So that it uses a logarithm and calculates it for you. So when patients with a high MELD scores are competitive for organs, the access to transplant for patients with a low MELD, which we clearly know that they need transplant also, is through living donation. So as you can see, the number of living donor transplants with a MELD less than 5 is much higher, as understandably so, than the patients with a MELD between 30 to 40, right? The high MELD patients can get deceased donor. The patients with a MELD anywhere from 11 to 28, it is very important to think about living donor liver transplantation. Not that high MELD patients cannot get living donor, they do well also, but they can get deceased donor very easily. This is also another slide just for you to understand, just very simple. There is definitely, let's say this is the probability of death curve, right? And this is the years of donor evaluation. Let's say LDLT means living donor liver transplantation. So living donor liver transplantation, the highest risk of dying is patient with a MELD more than 15 and no living donor. Or MELD more than 15, no living donor. Next is no living donor, MELD less than 15. And then living donor and who received MELD of 15 has a lower risk of dying. And the patients who survive the best are the living donor liver transplantation offered to patients with a MELD of less than 15, so they do well. And this is just, I wouldn't want you guys to get too, feel like too complicated with the slide. But what it actually shows is that the living donor, the survival benefit of living donor liver transplantation starts with as low as 11. And this mortality, we call it as the mortality risk models. All it means is that if somebody has a MELD of 11, the survival benefit starts at the MELD of 11, which means that the hazard ratio was 0.64. See, easy way to remember is 1 is the hazard ratio. Anything below 1 is good. Anything above 1 is bad. So the survival benefit of transplant starts at MELD 11. So it's actually less than 1, right? As you can see, stepwise manner. So all it means is that when you have a living donor, think about living donor liver transplantation earlier on. It doesn't matter what your MELD is. If your MELD score is as low as 11, but if you have the indication for transplantation, let's think about living donor taking you to a living donor liver transplant. So the living donation not only saves lives because living donor is given at the time when your not so decompensated, or you're in liver failure where the MELD is 30. And imagine yourself, right? Your MELD of 17 now. You feel reasonably okay. You're walking, you're talking. You obviously have multiple symptoms, but when your MELD is 35, you will be sick. You're in the ICU, you're in liver failure. So you're going to do well when you get the living donor liver transplant at the time when your MELD is lower and we can medically optimize you. So with the living donor, it gives you more power and more option to get you to transplant when you're medically optimized and feeling better. And now, with the living donation, you don't have to wait on the wait list. You can be taken out of the wait list and given a living donor liver transplantation. And so you can bypass all this. It definitely has mortality benefit, morbidity benefit, meaning you don't. So when you're on the wait list for 2 years, let's say you get admitted every couple of months for ammonia buildup or for bleeding. So you don't have to do any of that. If you're on the wait list and you have a living donor, we can take you to the living donor liver transplantation. So that's why I'm so passionate about living donation, because that is a way to save lives. And yeah, like I said, just to summarize, it's an elective surgery, non-emergent. We optimize the recipient before the transplant, and it gives some increased accessibility to transplant and at the right time. So here with the transplantation, the key word is access to liver transplant at the right time. Timing is of the essence. And so this is just, again, this talks about the patient survival and graft survival on our own patients at UPMC. So let's say this is the probability of survival. So the living donor has definitely 5% survival advantage over deceased donor liver transplantation. At 3 years, 86% of the living donor recipients survived as opposed to 80% of the deceased donor recipients. So it also shows that living donor has a better survival. It also talks about, so, the living donor liver transplant recipients had a smoother operative course, as demonstrated by less likelihood of needing intraoperative transfusion, which means blood or plasma, shorter hospitalization, and less likelihood of receiving a dialysis afterwards. And it also talks about the operation rate, the hepatic artery, all the operative risks are better with the living donor liver transplantation, except the biliary leak is a little higher, which as in the compared to the literature. But however, the early biliary leak was higher, but there was no late biliary stricture. So all I want you guys to take home is that living donor liver transplantation definitely offers a survival benefit, smoother post-operative course, better length of stay, easier recovery time, and less operative complications. And the other benefits of living donation is that you're allowing your family or your public, or you're leaning into the community to give them an opportunity to help you through this life-saving process, right? It is truly a life-saving procedure. You're giving an opportunity to your friends and family to give you a chance for your life. And like I said, better outcomes, recovery time is quicker, and post-operative course is much better with the living donor liver transplantation. So the reason why living donor works is that there is two amazing and unique properties of the liver. So the liver, the liver is divided into right and the left lobe. Right is 60%, left is 40%. Depending on the weight of the recipient, approximately 50 to 55 or little over 55% is taken from the right lobe of the liver and given to the recipient. In the donor, the liver regenerates to full size in approximately 8 to 12 weeks. And in the recipient, it takes around 12 to 14 weeks. So the liver has enormous capacity to regenerate. And during the time the liver is regenerating, both the recipient and the donor do not go into liver failure because the liver has enormous capacity to not only regenerate, but compensate and adapt to the needs of both the donor and the recipients during the time that they're regenerating. And there are some advantages and disadvantages of living donation, but disadvantages obviously is much higher than disadvantages. Reduce the waitlist mortality, get you to transplant at the right time before the transplant patient becomes critically ill, elective, non-emergent surgery, adds to the cadaveric pool. There is also a financial benefit to the patient and the community with living donor liver transplantation, because when the patient is given living donor liver transplantation at the right time, their mortality reduces and their admission to the hospital multiple times reduces. Imagine somebody who's a MELD of 14, but they go into the hospital every month. And when they get discharged, they become weaker than the previous admission. So those are some things you can bypass with a living donor liver transplantation. And yes, there is definitely some short-term risks to the donor, like pain, anesthetic reaction, or infection. And we talked to the donor extensively about it. And there is also decreased hepatic reserve in the donor for at least 8 to 10 weeks. But like I said, liver has enormous capacity not only to regenerate, but can also compensate during the time when it's regenerating. So, which is a unique property. So obviously, this is a teamwork. One person cannot do this. And we have a phenomenal team, which includes the surgeons, nurse coordinator, social worker like Lindsay, transplant physicians, living donor advocates, psychological, behavioral medicine, inpatient team. The ICU is so crucial. Pharmacy, case management, fiscal, and several others who has unique expertise in living donation. And I just wanted to talk about what is unique to UPMC. Most importantly, we have extended living donor liver transplantation to people with a cancer. We have also done paired exchanges. We'll talk about it in a second. And we also have increased altruistic donor. Because altruistic donors are the ones who actually they are non-directed donors. They come forward and they want us to match them with someone on the wait list. And our volume wise, we have been number one in the nation since 2017. And I only mention the volume because more volumes means more expertise of the team and less complications because we all become more and more proficient and efficient in doing the living donor. And a huge milestone for UPMC is that we have done more than 1,000 living donors 3 months ago. And that's first in USA. And then the unique program we have is a living donor champion program, which we'll talk about it in a second. And like I said, these are something new at UPMC, and other centers are also doing it. The Living Donor Champion program is unique here, and there are 2 or 3 hospitals who also do liver paired exchanges. And we are also extending living donor for extended and novel criteria, and we also have an incompatible protocol. So the Champion program, just a couple of slides on that. The Champion program was built at our center with the primary goal to overcome the biggest recipient barrier, right? The recipients usually, the first time I met them, they'll say they have a hesitancy in approaching a potential donor. I would be like this, I would be the same too. So this program was developed to help the recipients overcome the challenge of finding a potential donor and educate and create awareness about living donation. So we asked the recipient to identify a champion. The champion is the person who is championing the cause of finding a donor for the recipient. And that's identified by the patient within their support system. And they work with us in and utilizing the multiple tools of our champion toolkit and identifying a donor for the recipient. So the conceptual framework is predominantly is a multi-pronged approach utilizing the immediate family, the extended family, the community, the public, and the support network. It is a structured educational awareness program targeting education, also utilizing American Liver Foundation, UNOS, Donate Live, and a lot of those, and utilizing the social media. All it means is that we want the recipient to lean in on the community, believe in them, and let them help them. And the first, usually the recipient is asked to identify a champion. The champion could be a caregiver or anyone else, and they work with us directly, and we will help them in utilizing these tools. And this is just the outline of what the Living Donor Champion program has and the multiple resources. And for the sake of time, I won't go into all the details, but the most important information on this is the Champion Toolkit, which is available online and printed. Champion workshops, we do virtual and in person. And there is also a Facebook page, which is a Living Donor Champion website, and a Facebook page, which is support of the champion. And we also have a one-on-one coaching through a champion ambassador and also by the living donor hepatologist. And in this case, it's me. And we also have a living donor education and information session. So we do offer a lot of tools for the patients to utilize that. And this is our Living Donor Champion program. It was started in June of 2017 to January 2025. So the Champion program consists of utilizing the social media, utilizing the Champion Toolkit, Champion support group, and also the town hall attendance and the Champion program. So these are some numbers just for you, not for you to remember anything. All you have to take away point for home is that we do have a champion program, and we help our recipients find a living donor within their support system, within their relatives, or within their community, or even in the public. And this is just an example of some of the resources available for the patient. These are education brochures and video CDs, and this is our support group of Living Donor Champion and Living Donor Transplant on the Facebook. And like I said, there is a champion program where there is an ambassador who works with us, and that person offers one-on-one support to our recipients and their champions. And coming to what's the second new thing is that the liver paired exchange program. So since October 2019, we have done 27 pairs, which is 54 transplants. So let's say usually recipients ask me, oh, I'm blood type A, but my cousin is blood type B. How can we do this? And we usually tell them, that's okay. Let's bring the donor. If they're otherwise a good candidate, what we do is that, let's say a donor is blood type A, and that person is not a candidate for the recipient one, so we match them. So the donor one, which is blood type A, is matched with the recipient who's blood type A, and this recipient's donor who's blood type B is matched with the recipient one, which is blood type B. Sometimes we may not have, if they are urgent, we may not have two pairs waiting to be matched. So in that case, we utilize a non-directed donor. Non-directed donor or an altruistic donor is someone who comes forward and say, I want to donate my liver or kidney, and I want the program to make the best matching, and we trust the program, and please match me with whom you think my gift of life would go a long way. So those are usually typically blood type O. So what we do is we utilize the blood type O to the recipient who's blood type O, and that person's donor, who is this recipient's donor, is matched with the recipient too. So this way we help two pairs at the same time. That's the whole concept of the liver paired exchange. We can also call it as liver paired donation. This has been known in kidney for a long time, but with the UPMC, we have started doing it since 2019. And then I think with the liver, I think we were the one of the first centers who started doing liver paired exchanges. And this is a very, very important slide. So American society is very accepting of living donation. And this is the most altruistic country I've ever been to or known of. When they did a random survey in US, 70% of the people said they would be willing to be a living donor for someone they know. And 39% said we'll be willing to donate their liver or kidney to someone they don't know. And that is impressive. And that is American society. And I keep telling the recipients, please lean in on the community. More people want to help than not. So we need to trust in the humanity and trust in the support that the people are giving us. And we should leverage that kindness in a way that helps someone else which changes their life for the better. And that's the difference between life and death. As you can see, then this is very impressive, right? These are these are anonymous or altruistic or non-directed donors. Like I said, these are all the donors who come forward. They don't have any recipient in their mind. They want to do this good deed because they want to give back to the community in some way, or they're very altruistic. So as you can see, the number of altruistic donors at UPMC have gone up from 2016. And this is the number of altruistic donors nationwide who are approaching multiple other centers and asking to see if they can help someone. And that is very impactful. And I think that's just amazing, I would say. And as you see, the number of living donor, altruistic donor for the liver and kidney has been slowly going up because of increased education, public awareness. Previously, it's not that people didn't want to help, just that they didn't know about that the liver can grow back and that they are able to donate and the liver can completely regenerate. So once they are catching up once we are able to bridge the gap of knowledge among the public, more and more people are coming forward, and that is just so heartwarming to see. And the number of living donor liver transplant done at UPMC utilizing an altruistic and anonymous donor, look at the numbers. That's just so impressive, guys. Like, I know we all want to make a difference and we all want to give back, but these are all the people who come forward, want to make a difference, and they make that difference with conviction and they help someone else live. And that's just the choice they made. And thanks to all the donors that we have saved several lives throughout the whole US, and it couldn't be possible without a living donor. And also, the one thing I wanted to say is that living donor sometimes does not limit only to the patients on the wait list. Nowadays, the living donors offer to a lot of patients. Patients on the wait list, patients with liver failure, patients with the cancer, colon cancer, which they have, the tumor has spread to the liver, or they could be candidates on our, if they followed, if they or meet the criteria of our inclusion. And we offer it to blood. We offer bloodless surgery. This is offered to people with a cholangiocancer. Cholangiocarcinoma is the cancer in the bile duct, and it's offered to patients like that. So we, with the living donor, more and more patients are able to get living donor at the right time so that they can live. Then otherwise they would not have lived if they would not have received a transplant prior to implementation of these protocols. And so it's important to remember the utility of the living donor liver transplantation goes beyond the wait list. It's not only can be offered to all the patients on the wait list, but can be offered to other patients who cannot be listed for different reasons. But we do have protocols for living donor liver transplantation, especially what we call it as transplant oncology. And transplant oncology means people with the liver cancer, people with the bile duct cancer, people with the colon cancer, with the tumor gone into the liver, which are not resectable, and people with a neuroendocrine tumor and all kinds of cancer, but however, spread to the liver. We do have specific protocols though, but however, it's offered to those patients if they meet the protocol. And we have also done 2 bloodless surgery, and we have done liver and kidney live donor simultaneously. There has been, we have only done 1 pair, but we got liver from the son and kidney from the other son. And we have done dual organ donors, meaning there has been 41 donors who have donated liver, either here or in a different institution, came back for a kidney or vice versa. And that's impressive. Those donors, or the altruistic donor, came forward and donated both liver and kidney. And we also of donors with certain genetic subtypes have also been accepted as donors. And so these are just something to think about how we have expanded the living donor criteria. ABO incompatible, even if, so usually when there is a donor who's not compatible with the recipient due to, blood type matching, we usually do the liver paired exchange, right? Like you can match them, that's the easiest. But sometimes we can also do what's called as a ABO incompatible, but that's just the protocol. I wanted it to be there, but it's a little bit more cumbersome, and they need to be pre-treated. The recipients have to be pre-treated. You don't have to remember this, but just I put this slide just for you to know that the living donor, the limit of living donor, sky's the limit for living donor, and many things is possible because that we do have control over the age and the health of the donor, and also we can optimize the recipient. And so transplant oncology is something, it's new, it's upcoming, and we've been offering this, and all the other centers in USA is coming up to doing this. And this is the living donor liver transplantation for people with specific kinds of cancer. And that would be your take-home message also. And as I said, it's a choice to stop waiting and start living. And when you have a living donor, it gives you an option. It changes the narrative, and it gives you a better chance of survival. And you can get the transplant at the right time, and you don't have to suffer waiting on the wait list. And I truly do believe that living donor liver transplantation is the way to go for future, and that is truly life-saving, and that's the transplant done at the right time. And the number of transplant centers performing living donor liver transplant by volume is, there are only 2 centers who does more than 50 per year, and UPMC is 1 and San Antonio is the second. There's only a few which do more than 20, and only a few who does, there's only a few centers who do more than 20. More than 10, there are a lot more centers. So what I'm trying to get at is that we still have a long way to go in living donation. People in US are very altruistic. Why not educate about living donation? And thanks to ALF that we are able to do that. And how about we utilize the people who are kind-hearted and who want to help someone else, and continue the education to them to see if they can come forward to donate to other patients on the wait list. And also when we think about the living donation, we educate the care managers, the patients, the referral MDs that it doesn't matter what your MELD 3.0 is. If you're sick and if you qualify to receiving a transplant, then let's think about living donation. If we think the patient has a survival advantage when they get a transplant, let's think about living donation. Living donation is the first option, not the last resort. And this is the education we usually tell everybody. And the criteria for living donation should not be based on the MELD score, but should be based on whether the living donor liver transplant will provide a survival advantage over best other treatment or staying on the wait list. So it doesn't matter what your MELD is. If you need a transplant, you don't have to wait for a transplant. Let's work together in finding a living donor for you. And this is the UPMC liver transplant volume, and that truly changed since the time we introduced the champion program right here. So as you can see, our living donor liver transplantation UPMC has continued to grow, and it is because of the whole team. And this is the PD, and our liver transplant living donor also is growing as well, as you can see in this. So for living donor, your take-home message is, let's refer the patients early, and even the patient themselves can refer themselves. Let's get you to living donor before you decompensate or get sicker, and before you don't have a chance to get a liver transplant. Because there is a lot of patients who succumb to their disease. Let's get our patients to living donor liver transplant earlier on, as long as we believe that the living donor can save their lives or survival advantage. What I mean by that is sometimes patients MELD is 14, but they are not sick. They're doing well. They don't have admissions. They don't have any complications of liver disease. Patients like that, we can wait and watch. They don't, even if they have a living donor, they may not need a living donor liver transplant. When I say low MELD, sicker than the MELD or the ones, we need to think about living donor. Low MELD is anything less than 15 to 17, and sicker than the MELD means they have admissions to the hospital, losing weight, losing muscle mass, poor quality of life. They can't sleep, and they have esophageal varices, they have bleeding, they have anemia, they have ascites which needs to be drained, they have confusion, multiple admissions to the hospital, they're becoming frail, they're getting malnourished. Those are the patients I'm talking about. So last but not the least, I would also take this opportunity to introduce two of our new clinics at UPMC. One is called the Beacon Clinic. It's a clinic which is bridging excellence in advanced cancer care post solid organ transplantations, led by our hepatologist, Dr. Stella Chalai. Sorry about that. So the Beacon Clinic is it's a collaboration with the Hillman Cancer Center. And for patients who develop cancer after transplant or who received a transplant because of a cancer, they are followed along because their immunosuppression is usually slightly different from the regular transplant patients. So that is a clinic for you to utilize. And then we also have what's called as a LARC clinic. It's a very important clinic. It's a liver health and recovery clinic. It's a comprehensive multidisciplinary clinic for patients with alcohol use disorder and alcohol-associated liver disease, led by Dr. Allison Faust, our hepatologist, and she's the director of the Liver Health and Recovery Clinic. And please do keep these clinics in mind. One is for post-transplant in cancer patients, and one is the pre for patients who have alcohol use disorder and alcohol-associated liver disease. Thank you. And like I said, it takes a village to even raise a kid. So it is our transplant village at UPMC. It is a teamwork. And we take this job very seriously. We all do it with passion. And it is thanks to all our recipients and donors and people like ALF who spread the message. And we cannot do this without all of you. And I am very honored and humbled to be part of this amazing team at UPMC. And which comes to moving on to the next phenomenal speaker, Lindsay Weslow. And she is our senior social worker of both living donor, liver, and kidney donors. And she'll be addressing the available resources for the donors. And she's amazing. She's a great resource. She has helped tons of the living donors and the living donors and the kidney donors. So please tune in and hope you get something out of both our lectures. Thank you so much for this opportunity again, and thank you, ALF.
Thank you so much, Dr. Ganesh. That was a wonderful presentation, and thank you for the introduction. I really appreciate it. So I am going to share my screen and talk a little bit about my role as the living donor social worker. So just starting off to talk about the role itself. So as the living donor social worker, what we do is we meet with our potential living donors in our donor clinic, and we complete a psychosocial assessment. So the assessment is just different questions that we ask our patient to talk about their social support, their care plan for after donation, any history that's significant to their donation decision, and just kind of getting to know the donor. We then will discuss the donor candidacy in our selection committee meetings. Typically, in order to meet our criteria for social work, is the donor is required to have a confirmed caregiver and driver for after donation. So somebody who can look after them for about a week after they get home from the hospital, and then get them to and from their appointments because they're not going to be cleared to drive for just a little while. We also go over local lodging. So if a donor lives over 2 hours away from our center, they're required to stay locally for that first week. So we'll go over local, lodging in the area and then discuss any resources. And that's going to bring me to most of my presentation today. So the first and the biggest program that we go over with our donors is the National Living Donor Assistance Center. So I'm going to call it NALDAC from here on out because it is a mouthful. But NALDAC is a federal program that can provide up to $6,000 in financial assistance for living donors to help them with donation-related expenses. So that could be travel expenses, lost wages reimbursement, or dependent care reimbursement. The general eligibility guidelines are really anyone who's considering being a donor and someone who was a U.S. citizen or lawfully present here in the U.S. But the main eligibility guideline is this one. So the donor's eligibility is based on the recipient's household income. And the biggest question that I think I get in my job is why that is. So the reason for that, authorizing legislation actually mandates that the recipient's ability to pay must be taken into consideration. And that's because the National Organ and Transplant Act of 1984 has said that the recipient is allowed to reimburse their donor for some donation-related expenses. So there are some allowable expenses they can help their donor with, and that could be travel expenses, related to donation. But that doesn't mean that a recipient is ever expected to help their donor. We understand that that's definitely a difficult thing to do and a rare thing to do. Because of this legislation, that is why the recipient's household income is taken into consideration. So the eligibility guidelines for that are 350% of the federal poverty guidelines, and they are updated every year. This is the current guidelines that we are working with right now. So if a recipient is over the income guidelines, maybe like a slightly over, but they're of course unable to pay for their donor's expenses, which again, that's never an expectation. It's only if they're willing and able to do that. The recipient can fill out what's called this financial hardship waiver. So there is a recipient portion of the application that they would fill out as a part of the application process. And this page is on it for those recipients who are slightly over the guidelines. So they can use this to demonstrate some financial hardship, list different pharmacy co-pays, maybe insurance premiums that they pay, travel expenses, coming to and from the hospital. And if they're able to demonstrate like the difference that they're over the income guideline, then that might mean that a donor could be eligible for funding. And this is all dependent on the specific patient cases. This doesn't really guarantee that any donor could be eligible with completing this waiver. It's really only if the recipient is able to demonstrate kind of enough hardship to be within that guideline. So applying for NALDAC, so patients are not able to apply on their own. A registered filer must submit the required paperwork. So I'm the main registered filer here at our center. So I handle all of our applications. The process that we have at our center, so we actually screen our recipients ahead of time at their evaluation. This kind of helps us to streamline the process and avoid any hiccups along the way. So that way we know if a recipient is within the guidelines. So if a donor does come forward, we can reference that in their chart and know right away, okay, they're eligible or they're not eligible, and then move forward. So donors are educated on NALDAC when they connect with our donor team, and they will be sent an application if they're interested and eligible. And like I said earlier, there is a recipient application as well. So there's one that recipient fills out and there's one that donor fills out. And both of those must be completed and submitted back to me in order for the donor to apply. The applications itself take about 10 to 15 business days to be processed. They do need to be approved before surgery to receive any funding. So donors are not able to apply anytime after surgery. So it can get time sensitive. The funding is not retroactive either. So I always tell donors to apply as soon as they can if they want funding for their evaluation, their surgery, and their follow-up trips. And you don't need to be approved for donation to apply for funding. So a lot of donors might need help before they travel to their evaluation. So you can apply for this program before you're, even evaluated for donation. So just breaking down some of the areas of funding here. NODAC, and for the travel expenses, they can provide funding for hotel, airfare, your gas mileage and parking, meals while you're away from home. If you're flying and you need a rental car, even ground transportation, as well as accompanying people who are coming with you. And the way that they receive funding, the donors, they are sent a credit card with a pre-approved amount on it for their travel expenses, and that's what they would use for the travel expenses. For lost wages and dependent care, so obviously a donor is probably going to need to take some time off work at the very least to attend appointments, recover from surgery. So NODAC can provide up to 3 days for evaluation, 4 weeks for surgery, and 2 weeks for follow-up for lost wages. And then if a donor, if you need to pay a babysitter or a daycare to take care of your child while you recover or attend appointments, or for people who maybe care for an elderly adult, maybe your grandparent or an elderly parent, and you need to hire a caregiver for them, they can also reimburse expenses for dependent care as well. And the maximum is listed there as well. So that's NODAC. I'm going to move on to another program that's available to our donors here called the Casey Fund. This is a state program here in Pennsylvania that can assist donors and their family with the cost of lodging during or after their surgery. So it can provide up to $300 towards a hotel reservation at any of the participating hotels with the program. There's not really any eligibility criteria for this. The donor would just let me know where they're staying before they check in, and then I would just submit the necessary paperwork. Another question I get about this program, actually, people ask if you need to be a resident of Pennsylvania to apply for this, and you do not. It's just a state program that's available in Pennsylvania, so you do not have to live in PA to use this program. In fact, a lot of people that don't live in PA use it because they need to stay in a hotel. And last but not least, I'm going to go over fundraising. So fundraising can help with costs that don't go through insurance that are related to either transplant or donation. So it is available for both donors and recipients. For donors, it can help with costs, like I said, that might not go through the recipient's insurance. That could be maybe medication co-pays or travel expenses coming to and from the hospital. And then same with recipients. So any costs that don't go through their insurance, same thing with medication co-pays, travel expenses, any other types of like medical bills. Help Hope Live is the main website that we recommend. They are a medical nonprofit, and they actually have people there that can help you fundraise. So I get a lot of people might not understand how to start it. They might not really be very tech savvy or really have a lot of people to spread this awareness to have somebody donate. And one of the really great resources with Help Hope Live is they have people who work with them that can work with the patient or the fundraiser on how to get started, how to set up their account, strategies to spread awareness, that kind of thing. The way that this particular nonprofit works is it is online. So the donor or recipient would open a fundraising account on Help Hope Live's website, share the link to their community, their support network, and then people can donate to that particular fundraiser. And those funds are then dispersed to the patient or to the recipient or donor as they need them. And fundraising can start anywhere in the transplant or donation process. You don't have to wait until you're approved or listed for transplant. You can start this at the very start, like before your evaluation, and even post transplant as well. That was everything that I had. You can always reach out with any questions. And if you have any particular other questions, you can always reach out to your team at your center. And if it happens to be our center, I'm happy to talk to anybody.
Hey, well, thank you so much, Dr. Ganesh and Lindsay. Your presentations were so insightful. It brought back so many memories of my husband's living donor transplant, and just incredible information that you all shared. I hope all of you at home feel informed and inspired as well. So. Okay, we are now open for questions and answers. And I see we have quite a few questions in the chat already. Okay, let's get to it. Okay, so Dr. Ganesh, please explain how this process differs from a transplant from a deceased donor.
Sure. Thank you, Lorraine. For the recipient process is the same, both for the deceased and the living donor. So the recipients have a complete evaluation done medically, surgically. They get all the testing, the scan, the images. They'll be seen by social work, psychiatry if they needed to. So the whole process of getting on the wait list is the same for deceased and the living donor. But once they get on the wait list, and then and then there's a living donor, and we take them off of the list, and then get them a living donor liver transplant. Sometimes we also go through this. Some of the patients are not eligible for deceased donor because of the way how the protocols are, but we do have living donor protocols specifically to them. But the recipient process is the same. They have to be medically, surgically, and the whole team have to say that they're good candidates for transplant before we approve them for transplant. So the process for the recipient is the same. Does it help?
Yes, that's great. So moving on, another question for you, Dr. Ganesh. What criteria is used for selecting a living liver donor?
Sure, that's a great question. So usually we at UPMC, we most of the centers have the similar criteria, but at least we want the donors to be reasonably healthy between the ages of 18 through 60. No major medical issues like active cancer, HIV, hepatitis B, or hepatitis C. No active substance use, any kind of substance or alcohol. And usually we expect them to be in the weight range less than 32 of BMI. So overall, healthy individuals is what we are looking at. If they have hypertension on one medication, that doesn't necessarily rule them out to be a donor. So overall, they have to be reasonably healthy.
Okay, another question for you, Dr. Ganesh. What items will, I guess this is from someone expecting a transplant, what items will I need post-transplant to help me recover and also my donor?
You mean, I'm sorry, items? Can you clarify, please?
Yeah, that's all it says in
Okay.
chat. I
Okay.
assume, I don't know.
Okay, so I think so for the donor, majority of the donors are discharged between 4 to 6 days, and we expect them, both the donor and the recipients, to have individual caregiver plan. And once the donors go home, they don't go home on too many medications. They go home on a baby aspirin, something for constipation and pain. They don't need any. So they're mostly their caregiving includes that they need somebody to bring them for evaluation. They do have weight restrictions of not lifting anything beyond 10 pounds, and they'll come back for an appointment at 1 week and 3 months and 6 months, 1 year, and 2 years. So the recipient, so the donor, this is the donor follow-up, and we do ask them to be on a low-fat diet for at least 3 to 4 weeks after the donation process. We ask them to not drink for 30 days after donation. We ask them not to smoke. So these are some housekeeping and the things the donors would need. For the recipients, their hospital course and recovery will look different than the donors. So usually the recipients can be in the hospital anywhere from 10 days to 3 weeks or 4. And sometimes they are discharged home with physical therapy, or they go to a rehab unit to gain more strength. They're asked to stay within the area for at least 6 weeks so that we can keep a close eye on them. They may even go home on a drain, which doesn't happen on the donor. And for the caregiver, for the recipient, is much more involved, that the caregiver needs to be with them closely, bring them to appointments, make sure they take medications. So the recipient is, the recipient follow-up and the donor follow-up looks different.
I was just going to talk about the caregiver. I remember being that caregiver very well for both my husband, but also my stepson, our living donor. And yeah, it's a big job, and
Sure. Absolutely.
and a lot to happen for the caregiver. So the biggest item that you need is a real strong caregiver. And
Absolutely.
anyway, okay. Another question for Dr. Ganesh. Can you tell us about blood type compatibility requirements, if any, for transplant and organ donation? I know you referenced that earlier, but maybe you can answer this question as well.
Sure, absolutely. So for a blood type A can receive organ only from A or O. For a B blood type, they can receive an organ from O or a B. AB is the universal recipient, so they can get organ from A, B, AB, and O. O is a universal donor, but they can only receive from O. Plus and negative and positive doesn't matter. And as you said, usually the blood type compatibility we watch, but if somebody has an incompatible donor but they're a good donor, we still bring them and we do the liver pad exchange. So and also we have a ABO incompatible protocol. So for the for the most part, those are some things to remember. But if you have a good donor who's not your same blood type, please do not discourage them. Let them register, and we'll get them evaluated, and we can do a liver pad exchange for them.
Such an amazing process. Just so exciting that that is an option for families.
Absolutely.
Okay, Lindsay, it's now your turn. Here's the question in chat. Will my insurance cover the costs of becoming a living donor?
Yeah, so that question, typically the medical aspect of donation should go through the recipient's insurance. However, the best thing to do would be to speak with your fiscal analyst. So on our transplant teams and donor teams, we do have a fiscal team, and they would go over those specific, coverages or requirements with the patient. So I would say that typically it should, but the best thing would be to just check on that with your fiscal team, just because it might depend on the insurance plan or other factors related to the situation. So.
Thank you, Lindsay. I remember that as well. You're so fearful because these surgeries are so expensive, and it's great to have the strong team to advise families, and so thank you. Okay, Dr. Ganesh, how many times must I be reevaluated when searching for a living donor match?
Um, So you mean, does it mean that, so the question is how many times they have to be, so when a
Yeah.
recipient is on the wait list, so let's say we get a referral and the recipient comes in, we evaluate them, and as a team, we make a determination that they're a good candidate for transplant. Then we get them listed for both deceased organ and also a living donor liver transplant. While they're on the recipient wait list, they don't have to be reevaluated for transplant, but every year they'll have to get an updated testing, lab work every 3 months, and a CT scan once in 6 months or so. And then they also get a stress test once a year. So they don't have to go through the reevaluation process every time. But however, when we talk to the recipient in trying to help them identify a donor, they may have to use multiple tools to find a donor. Let's say the recipient, we ask them to put a Facebook post, and they have to, maybe revisit the post, update the post. So they may have to do that kind of a homework several times before we can find a living donor. And once, let's say, they find a living donor, we get them evaluated, and then they are good donors, but they are not able to go within 6 months to a year. Those testing done for the donor is good for a year. We don't have to repeat any of those testing for up to a year or so for the donor. Does that answer the question?
I think it does. Let's hope so.
Okay.
Okay, so thank you so much, Dr. Ganesh. And now, Lindsay, here is another question. Okay, so after my liver transplant, will I be eligible for disability? Assume that's disability insurance. And what about my living donor?
Um, I'm assuming that means maybe a social security disability. I feel like that might be a common question.
Oh, you may be right.
I
Yeah.
think so that I can speak on that.
Okay.
However, like again, I can't really give like a general answer just because that really depends on the person. Disability eligibility, like basically depends on your diagnosis, what you're applying for, and how well you're doing, like if you're unable to go to work. So again, that's really just a scenario that is based on the specific patient situation. So can't really give like a whole general answer on that.
Sure. And that's true of living donor as well. So both the patient, yeah. It's hard to answer. It's a more specific question for each. Yeah. Okay. So Dr. Ganesh, you talked about MELD scores, I know. So this question says, how does my MELD score factor into the living liver transplant process, and is it case by case?
That's great, Lorraine. So that's the best thing about living donor liver transplantation. We don't have to look at the MELD. If we think that they need a liver transplant and living donors transplant is going to offer a survival benefit, then they do not have to, like I said, the MELD does not have to factor into the living donor. And the survival benefit for living donor liver transplant starts as low as the MELD of 11. So they can have low MELD, medium MELD, high MELD. With the living donor liver transplantation, MELD does not change the allocation because they have a donor. They can get the transplant at any point in time.
And along with that, Dr. Ganesh, my own question, I understand that like people with autoimmune liver disease tend to have lower MELDs, and it may not qualify, for a deceased organ, but this would be possible. Do I have that right?
Absolutely, 100% Lorraine. That's the best thing about living donation. You're right. In some of the autoimmune diseases, PSC, PBC, the MELD does not reflect how sick they are, but they're definitely sick. Their MELD is low and they cannot get a deceased donor at the right time. And those are perfect candidates for living donor liver transplantation.
We have a huge community of passionate autoimmune liver disease patients. So I hope they really take note of that. This is the way they can get well.
Absolutely.
So and
Absolutely.
move forward. So, well, thank you so much. Okay,
Yes.
another question in the chat, Lindsay. What resources are available for living donors? I read that they may be eligible for assistance with lost wages, travel. Okay, so what resources are available for living donors? I read they may be eligible. So you, in a way, already described this with NELDEC, right?
Yes. Yeah. So the
So
resources I mentioned, NODAC is the biggest one. So they can, again, assist with travel expenses, lost wages, or dependent care reimbursement. That is the biggest one. There might be like some other types of grants out there. If a donor isn't eligible for NODAC, they can always reach out to myself or their social worker directly to see if there are other resources available that they might be eligible for.
And Lindsay, your section of your presentation on all of this was fascinating. I took a lot of notes. I wasn't aware of the KC plan and in Pennsylvania and all, and
Mhm.
that was really incredible. So thanks for sharing.
Of course, thanks.
I assume, wasn't that your governor at one point? And wasn't he an organ? He had involved in organs, I believe.
Yes, I think that it is something I think they either it is based off of him.
Yeah.
It is
Yeah.
from that.
Yeah, an extraordinary family who's been passionate about transplants. So anyway, I just wanted to add that. And there may be some other opportunities in some other states, and I encourage you to take a look, all of you on this call who are seeking a transplant. Okay, couple more it looks like. Let's see. Oh, let's see. Okay, if you wait a second. Okay. Are there any? Oh, Dr. Ganesh? My my wife is thinking about becoming a living donor. What might recovery look like? How long? And how can I best help her? Oh, how sweet.
Sure. And so for the donor, like I said before, usually depending on the weight of the recipient, approximately 50 to 55% of the right lobe is taken out. The donor is in the hospital between 4 to 6 days. And when they go home, their JP is out, and usually they're sent home on only some pain medications and baby aspirin and something for nausea and constipation. They do have significant weight restrictions up to 10 weeks or so. They cannot lift anything beyond 10 pounds. And they can slowly start they also have restrictions of how much they can work out. So usually we ask them to start slow, do some walking, but not do anything which increases their intra-abdominal pressure. And the caregiving for them, maybe not much though, but we ask the caregiver to be with them, bring them for appointments, make sure they take care of themselves. They can have fatigue as an extreme symptom up to 4 to 6 weeks. They may feel like they're back to baseline in 4 to 6 weeks. We may even able to get them back to work on a light duty. But however, if it is a more of a cognitive job, they can go back to work at 4 to 6 weeks, depending on how they feel. But if it's more of a physical job, we ask them to take the entire 10 to 12 weeks off so that they don't lift anything or damage anything in the process. There is also risk of incisional hernia up to 12 weeks, and that's why we ask them to make sure that they don't lift anything or don't do anything which increases their intra-abdominal pressure. So, in this case, the husband can, do some laundry and get some groceries, cooking, all of that, and they'll be on pain medications for at least 2 to 3 weeks afterwards, and they may not be able to think clearly. So we ask them not to operate any heavy machinery, no driving for a period of time, and also not cook in the oven. So those kind of things. The husband can support her really truly by running the errands, taking care of herself, healthy meals, making sure she comes for the appointment at the right time, and bringing her for appointments and helping her do the walking and get her back to the routine slowly. Seems like he's a very supportive husband, and I'm sure, everything will go well.
That is great. I have a flashback of being at a 24-hour pharmacy at 2 in the morning while to pick up a prescription that got called in very last minute. So sometimes those running the errands become very, very important, right?
Absolutely, Lorraine.
So,
You're
yeah,
100% right. And you're right. Sometimes they may have more pain, or during the process of recovery, they may develop a urinary tract infection or a cough. We ask
yes.
our donors to call us at any time. We have 24/7 on-call person who can answer their question. And let's say they develop a sore throat and a strep pharyngitis, we can give an antibiotic, and a husband probably have to go pick it up. Sometimes things like that happen too, but they have 100% access to us 24/7 because somebody is on call all the time for any issues that occur with the donor.
That's exactly, you just described what happened to us. Something came up. I think it might have been a UTI. They picked up on it, and good thing there are 24-hour pharmacies.
True, true, very
That,
true.
yeah. So, well, this is an interesting question. In the chat, can I only be a living donor to one person?
Um, we have so we have a lot of donors who have donated kidney, and we usually bring them back if they're interested in liver a year later. So they can definitely be a donor for more than one, but not at the same time. But if they're asking about if they donated a liver once, can they donate liver again? That answer would be no.
Yeah.
But they can donate kidney though, and a year later they can come back to liver once those kind of things they can do. They can do blood donation.
Yeah.
All that is okay. But yes, sometimes donors do ask me, "Oh, I donated my liver now. Can I donate 3 years later?" I said, "No. It's for your goodness of heart, but you may not be able
Yeah.
to. You're not able to do that."
But there are a lot of people with liver disease who find
Yeah.
out they need a kidney. And my gosh, we at the American Liver Foundation, really encourage all of living donation, including kidneys.
Absolutely. Yes.
Yeah,
Is
so
it what
important.
changed your path to come to ALF? That your own journey with your husband, if may I ask that?
Oh, yes. Yes, a little bit. Yes, a lot of it is transplant and why I arrived at liver, but I also have done a lot in diabetes. And as we all know, a lot of people with diabetes and obesity end up getting fatty liver,
Sure.
steatotic liver disease. Steatosis means liver, fat, right?
Fat.
And
Yep. Mhm.
so in the end, the growing epidemic,
Oh,
I think is what compelled me here. We need to do so much more, and thankfully, the American Liver Foundation is really stepping up in a big way to do so.
yeah, absolutely. And thanks for all that you guys do at ALF.
Oh, yes, and we've just scratched the surface of everything we want to do, and clearly, living liver donor transplantation is so important. Lots of resources. I think we have just a couple of more questions. I think I'm just looking at the chat. There seems to, I think a lot of these have been asked, so I'm going to kind of skip through them quickly. But Lindsay, are there age requirements in every state to become a living donor?
So I'm not sure if the states differ, but Dr. Ganesh can probably agree with me. So for liver donors, you do need to be at 60 years, between 18 and 60 years old.
Yeah.
For kidney, it's 18 and 75 years old. But I'm not sure if it differs per state. I don't know if you know, Dr. Ganesh.
Lindsay, I agree with you. And different programs have a slightly different cutoff for age. Some centers have 55, some have 62. So every center is different in that. And in our center, like Lindsay said, for living donor, it's 18 through 60 for liver.
Right. And it seems like kidney, well, since we are on the subject of kidney, and so many liver patients need kidneys, many
Yes,
do. I heard you can be older to donate a kidney. Maybe I
that's
don't
right.
know if that's true at UPMC.
Yes, that's right. Like
Yeah,
Lindsay said, the age
yeah,
cutoff is
yeah.
75, Lindsay, for kidney.
75 was kidney. Okay. Okay. Well, thank you. And then okay, Dr. Ganesh, if I already have someone willing to be my living donor, do I have to wait until I get sicker to begin the transplant process?
No, no. If even if they don't have a donor, if they are sicker, we should immediately start the transplant evaluation process in them. That's why one of our education is refer early, so we can get them on the wait list and help them find a donor. And especially if they already have a potential donor in their mind, we should start the process on them immediately. And if they're sicker than the meld and they need a transplant, we should get them to living donor as soon as we have cleared the recipient and the donor.
Okay. I thank everybody for all the questions that have come through chat. There's Dr. Ganesh, here's one. Is there any benefit to the child of a patient becoming their living donor versus someone else unrelated? I assume that's adult child?
So is it a benefit for, so the question is whether the donor should be related or not related?
Yeah, I think
Okay,
that's what this patient might have been asking.
sure. So I think the one I could answer this in two ways. So for the adult recipient, it doesn't have to be. In fact, it's hard to find a first degree biological or a second degree relative to be a donor, right? 50% of our donors are either a friend or a distant cousin or even a stranger sometimes donate. So they do not have to be related to the recipient at all in an adult recipient. The donor can be anyone. And in a child also, it's exactly the same role. We used to believe that there is immunological advantage if the parent gave the liver to the child. In fact, for some genetic diseases children have, the parents cannot be even the donors. So anyone could be a donor. They don't have to be related to the child recipient or the adult recipient. They could be first degree relative, second degree relative, or stranger or a friend. Anyone could be a donor as long as they're healthy.
Okay, thank you, Dr. Ganesh. And I think this will be our last question. And Lindsay, you have that question. How can I find a living donor? And how long does it normally take to find one?
So Dr. Ganesh had some wonderful slides on that actually in her presentation. So for finding a donor, it's really just spreading awareness, and that can be in many ways. So I think that she had mentioned like social media, spreading awareness among like your support, your family, your support network, your community, maybe like your spiritual centers, maybe at work, or posting, like I said, online, social media and whatnot. Some people will get billboards, might hand out flyers. So there's really a lot of ways that you can look for a living donor. And a really great way that, is utilizing that champion program. So we have that wonderful program here where we have champion ambassadors that work with our recipients specifically on that, to strategies where they can find, look for a living donor, how to spread awareness. So it's just a really great resource that we have. As for the time frame, I'm actually not sure. I don't know if I can really give an estimate on how long it might take to find a living donor. I think that really depends on the situation. I don't know if there are statistics on that. I may have to look that up. But I don't know if Dr. Ganesh knows anything about that.
No, Lindsay, very well summarized on how to find a living donor. Perfectly agree with everything you said. And like Lindsay said, we do have this amazing program called Champion Program, which really has changed the landscape of the volume of living donor at UPMC. It's a great program. We would like for all the patients to utilize that. You can even go into the Google and get the online kit for the Champion Program from UPMC. Even if you're in a different center, you can still use that. And Lindsay, I don't think we have any statistics on looking at how long. And like you said, it could be anywhere from 2 weeks to 3 months, or sometimes some of our patients wait for 6 months to find a donor, or sometimes longer. But we encourage them to keep looking, keep trying, keep at it. Like Lindsay said, church group, the local word of mouth, alumni association, the book club, anywhere you can find. Or the Facebook has been our most success thus far to finding a living donor.
All good to know. And the American Liver Foundation, we also have these amazing videos. I think there are 4, maybe there's 5, that really help outline how you can go on social media and how you can ask family and friends. It's sometimes hard, and you need that knowledge and encouragement. So UPMC has lots of resources, as does the American Liver Foundation. So I think unfortunately we have reached the end of our time together. Everyone who registered will receive a follow-up email with a recording of this program and a list of resources and support services provided during the presentation. We hope this has been helpful to you. Of course, if you have any questions about the University of Pittsburgh Medical Center, please visit their website at www.upmc.com/transplant. And if you have more questions about liver disease, the American Liver Foundation is here to help. Call our free helpline at 1-800-GO-LIVER, or visit liverfoundation.org, our website, to view our robust library of educational resources and support services for patient and caregivers, including our Living Donor Liver Transplant Center, our National Transplant Center Finder, and so many other resources. So encourage you to go to 1-800-GO-LIVER or liverfoundation.org. Thank you once again for joining, and we hope to see you again soon.